So hello. We are here at the EMA meeting, the 15th EMA meeting here in Vienna. My name is Heinz Ludwig. I'm a medical oncologist, hematologist, working at the Wilhelminen Cancer Hospital in Vienna. And my partner here is Professor Niels van der Donk. He is member of the Free University Medical Faculty of Amsterdam. And so the question popped up, what can we do in a patient who has been exposed to daratumumab, who responded for quite a while, but then became resistant. Mm-hmm. So are there data which support re-exposure of this very patient to daratumumab? Or what can we do to modify the tumor cell to make it more sensitive to re-exposure?
Mm-hmm. So we have now limited data available that patients that received daratumumab as monotherapy responded and then progressed, got another therapy, and then were exposed to daratumumab again, that these patients can respond to dara again, but we have to learn much more about retreatment and how to position retreatment. With or without interval?
Would there be an interval because you have this long half-life of daratumumab?
Yeah.
So would you wait for 3 months, half a year?
I think we have to learn from clinical trials that are currently being developed, and it will also be different when you give dara monotherapy or you will give dara in combination with another drug. And I can envision that daratumumab can be a very interesting backbone because of its effects on the immune system, its effects on the microenvironment, and maybe you have to change then dara-Lendex to dara-Veldex, and maybe that will be effective. But we have to learn from clinical trials that are going to learn us more about retreatment. In the meanwhile, in our laboratory, in our clinical trials, we are also looking at mechanisms of resistance of daratumumab. And one of the things that we saw is that there is upregulation of complement inhibitors at the time of resistance, and also very early already, both in responders and in non-responders, a downregulation of the target antigen CD38. So now we are also trying to retreat patients with daratumumab in combination with all-trans retinoic acid, which reduces complement inhibitors and increases the target antigen. And this is a phase 1/2 trial, so also there we have to learn much more. In the preclinical setting, it works perfectly well in mice and in ex vivo experiments, but now the proof of the pudding will be, of course, the phase 1/2 trial that we are running. And then I think also in patients that relapse on daratumumab, it will be very interesting to see how effective it will be to add, for example, a checkpoint inhibitor to further activate the immune system that has been improved by daratumumab. And these trials are currently enrolling patients, so very exciting times.
Exciting times, and I like your attitude that you want to have data, scientific evidence-based data before we come to a conclusion. That is a risk in medicine, that people are inclined to move too fast to, let's say, a certain recommendation without enough evidence. So I think we should keep that in mind. And I think there are certain examples in myeloma as well, to be honest.